Hello, good morning, doctors. Today we are on 11th day of reading Oxford Handbook of General Practice. I am your study buddy, Dr. Sesha, and we are preparing together for the MRCGP AKT exam. We are on page number 308. We will start from respiratory medicine today. Snoring and obstructive sleep apnea. Snoring. During sleep, the pharyngeal airway narrows due to decrease in dilator muscle tone. Snoring is a vibrating noise generated from the pharynx and the soft palate as the air passes through the narrowed space. Further narrowing produces louder snoring and labored inspiration and eventually apneic episodes. Social consequences are the usual reason for the patient to seek help. This can be distressing, like banishment from the bedroom, marital disharmony, no holidays, fear of traveling, falling asleep in a public place, etc. Snoring may be used by the spouse as an excuse to leave the marital bed and may actually be a trivial or absent. If suspected, ask the patient to bring a recording of the offending noise. Obstructive sleep apnea occurs when the pharyngeal airway completely closes during sleep, resulting in apneic episodes. Increased inspiratory effort is sensed by the brain and then a transient arousal provoked. A few of these arousals don't matter, but many, sometimes hundreds per night, cause fragmented sleep and consequent daytime sleepiness. Affects 4% of the males and 2% of the females in the UK. Clinical features. Dominant features are excessive daytime sleepiness, not tiredness. Epworth Sleepiness Scale is a useful assessment tool. Impaired concentration, snoring. Other features: unrefreshing sleep, choking episodes during sleep, witnessed apneic episodes, restless sleep, irritability or personality change, nocturia, and decreased libido. Other causes of snoring and sleep apnea: overweight, neck circumference more than 43 centimeters, nasal congestion, evening alcohol or sedatives, large tonsils, receding lower jaw, smoking, hypothyroidism, menopause. Management: snoring without sleep apnea. Initial approaches suggest changing in sleeping position, discourage from sleeping on the back, elevate the head of the bed, prop up on bricks, can decrease the nasal congestion. Limit the number of pillows to half, one thick or two thin pillows to maximize pharyngeal size. Decrease the weight if obese and decrease or stop even alcohol or sleeping tablets. Suggest a partner tries earplugs purchased from chemist. Take several nights to get used to wearing them. If clinically indicated, nasal congestion. Start a beclomethasone nasal spray applied head downwards. 2 puffs BD plus ipratropium bromide nasal spray, 2 puffs Nocte. Check TFTs to exclude hypothyroidism. If simple measures fail, refer to dentist or ENT for a mandibular advancement device, ENT for surgery, septal straightening, polypectomy, turbinate reduction, tonsillectomy, uveopalatal pharyngoplasty. These are when there is no sleep apnea. But when there is sleep apnea, advise the patients to decrease weight if obese or decrease or stop evening alcohol or sleeping tablets and refer to sleep unit or physician with a special interest in sleep problems. If diagnosis proven and causing significant daytime sleepiness, usual treatment is with CPAP therapy at night. Mandibular advancement devices are alternatives for parents who cannot tolerate CPAP or have very mild symptoms with no daytime sleepiness. Occasionally, if large tonsils, refer to ENT for surgery is warranted. Complications: high BP, diabetes, increased risk of stroke and road traffic accidents. The Epworth Sleepiness Scale is how likely are you to doze off or fall asleep in the following situations in contrast to feeling just tired. This refers to your usual way of life in recent times. Even if you have not done some of these things recently, try to work on how they would have affected you. So situation: sitting and reading, chance of dozing; watching TV, chance of dozing; sitting inactive in a public place, theater or a meeting; as a passenger in a car for an hour without break; lying down to rest in the afternoon when circumstances permit; sitting and talking to someone; sitting quietly after lunch without alcohol; in the car while stopped for a few minutes in traffic. 0 is no chance of dozing, 1 is slight chance of dozing, and 2 is moderate chance, and 3 is high chance. If the score is more than 10, consider sleep apnea. Driving: warn the patients not to drive if sleepy. Once diagnosis is confirmed, they must inform the DVLA and the insurance company. Sleep apnea in children: Common in children is 2 to 7 years in association with tonsil enlargement during upper respiratory tract infection. Sleep disruption can cause daytime sleepiness, hyperactivity, poor attention span, and bad behavior. If the tonsils are big enough to produce sleep apnea in the absence of current infection, refer to an ENT for consideration of tonsillectomy. So next chapter is endocrinology. So let's scroll to page number 312. Chapter is endocrinology, symptoms of endocrine disease. Hormones secreted by the endocrine system perform a wide range of functions. Therefore, clinical presentation for different endocrine disorders varies widely from non-specific symptoms such as tiredness to very specific signs such as delayed puberty. Specific features depend on the gland and hormones involved. Polydipsia, frequent over-frequent drinking of fluid, often associated with logical reasoning with polyuria. Ask if associated with thirst. Take a history of fluid intake. If no history of excess fluid intake, capillary blood glucose or fasting blood glucose, HbA1c is normal. Investigate further with urea and electrolytes, creatinine, EGFR and calcium. Common causes of polydipsia: change in lifestyle. Diet, activity, exercise level may be associated with polyuria but not other symptoms. No history of thirst. Diabetes, usually accompanied by a history of thirst. Other causes: diarrhea, diabetes insipidus, increase in calcium, compulsive water drinking may be a feature of psychotic illness, and phosphorus poisoning. All of these are other causes of polydipsia. Polyuria. Passage of excessive urine. Check the patient does not mean frequency of urination. It can be difficult to distinguish the two. Causes are similar to those of polydipsia and two symptoms are related. Take history of fluid intake. If no history of excess fluid intake and capillary blood glucose or fasting blood glucose or HbA1c is normal, investigate further with MSU, midstream urine, for microscopy and culture sensitivity. Urea electrolytes, creatinine, EGFR and calcium. Consider diabetes, diabetes insipidus, hypercalcemia, excessive intake due to change in lifestyle or psychiatric conditions. Examples: schizophrenia, chronic renal failure, drugs like diuretics, caffeine and alcohol. Glycosuria, often detected incidentally on urine dipstick. Causes are diabetes, sepsis, low renal threshold, pregnancy, renal tubular damage. In all the cases, check HbA1c, fasting blood glucose. So in all cases of polyuria, polydipsia, glycosuria, you check first whether they are diabetic. It's one of the most important causes. Plus, so in this case of glycosuria, check HbA1c or fasting glucose plus glucose tolerance test if they are pregnant. Check immediate capillary blood glucose if other symptoms are suggestive of diabetes. Hirsutism affects 10% of the patients, females. Excessive hair in androgen distribution. Causes are: most cases are idiopathic. They may be family history. Drugs like phenytoin, steroids, corticosteroids, cyclosporin, androgenic oral contraception, anabolic steroids, minoxidil, diazoxide, all of these drugs cause hirsutism. Phenytoin is a very important cause. Polycystic ovarian syndrome, Cushing syndrome, late onset congenital hyperplasia rare, ovarian tumors. These are all causes. Assessment: history, long standing or recent onset family history, ethnic origin if more common in Mediterranean origin, and menstrual history. Examination: distribution of excess hair. Investigation: women with long-standing hirsutism since puberty and regular periods need no further investigation unless abnormal signs. Otherwise, blood testosterone levels, which is increase in PCOS, androgen secreting tumor or late onset congenital hyperplasia, you have to get this investigation done in case the onset is acute and not since puberty. And LH-FSS ratio, that is suggestive of PCOS. That is, if LH-FSS ratio is more than 3:1. Refer for a gynecologist or endocrinologist. If recent onset, abnormal blood tests, virilism, galactorrhea, menstrual disturbance, infertility, or a pelvic mass. then you have to refer to an endocrinologist. So you have to refer to a gynecologist or endocrinologist if recent onset, abnormal blood tests are there, virilism, galactorrhea, menstrual disturbance, infertility, or a pelvic mass is present. Treatment for idiopathic hirsutism. Cosmetic, bleaching, shaving, waxing, depilatory creams, electrolysis, weight loss in obese individuals, psychological support, topical enflornithine reduces the growth of unwanted facial hair. Continuous use for more than 8 weeks is required before the benefit is seen. Must be used indefinitely to prevent regrowth. Discontinue if no symptoms improvement in 4 months. Oral medication. All must be taken for more than 6 months to take effect and none abolish the problem. In this case, continue treatment until acceptable level of hair growth, then stop. Relapse usually occurs following withdrawal and repeat courses are required. Drugs used for them are COCP pills containing desogestrel or cocyprindole and spironolactone. Sweating, facial flushing, delayed or precocious puberty, obesity. These are all the symptoms of endocrine disease. Metabolic syndrome, syndrome X or insulin resistance syndrome, impaired glucose tolerance or diabetes, insulin resistance in patients on insulin, suggested by insulin doses more than 1 unit per kg per day, or plus other risk factors for CVD including truncal obesity, that is the waist circumference is more than 0.9 meters in males and in females and more than 1 meter in males. Subtract minus 0.1 meters from these figures for people of South Asian extraction. High BP more than 135 by 80. Dyslipidemia, serum HDL less than 1.2 millimoles per liter in females or less than 1 millimoles per liter in males. Fasting serum triglycerides more than 1.8 millimoles per liter. So these are the three components of metabolic syndrome. One is impaired glucose tolerance and insulin resistance, truncal obesity, high BP and dyslipidemia. Associated with a high risk of CVD, treat the risk factors aggressively. Tiredness and lethargy. Diabetes mellitus. Diabetes is the most common syndrome caused by lack or decreased effectiveness of endogenous insulin. It affects 3% of the UK population and is characterized by increased blood glucose plus abnormalities of carbohydrate and lipid metabolism. Classification of primary diabetes. Type 1 occurs at any age but is more common in those less than 30 years. Autoimmune disease, islet cell antibodies may be present initially associated with other autoimmune diseases and certain genotypes like HLA-DR34. Although identical twin concordance is 30%. Patients are prone to profound weight loss and ketoacidosis. Insulin is needed from diagnosis. In type 1, presents with weight loss and ketoacidosis. Do not measure the C-peptide or diabetes-specific autoantibody titers to confirm the diabetes of type 1 diabetes in adults. Type 2 diabetes. 80 to 90% patient with diabetes mellitus Type 2 diabetes, 80 to 90% patient with diabetes are type 2 diabetes. Males more than females, 3:2 ratio. Prevalence is rising. Progressive disease resulting from decrease in insulin secretion and insulin resistance. Onset is often insidious. Half of them have complications at diagnosis. Risk factors, age is more than 7. Progressive decrease resulting from decreased insulin secretion and insulin resistance. Onset is often insidious. Half of them have complications at diagnosis. Risk factors. Age is more than 65 years. Pre-diabetes, obesity, family history of diabetes, identical twin concordance is 100%. Ethnic group, South Asians or Afro-Caribbeans have 5 to 10% increased risk. PMH of gestational diabetes or a baby more than 4 kgs at birth. Latent autoimmune diabetes in the adult. This is another variety. 6 to 10% of patients with type 2 diabetes characterized by anti-glutamic acid decarboxylase antibodies associated with high risk of ketoacidosis and increased risk progression to insulin dependence. Suspect if type 2 diabetes and absence of metabolic features, uncontrolled hyperglycemia despite oral agents, or other autoimmune diseases like thyroid disease and pernicious anemia. In those cases, we don't have a typical type 2 diabetes profile. In that case, you need to suspect latent autoimmune diabetes of the adults. Maturity onset diabetes of the young. MODI, 1 to 2% patient with diabetes mellitus presents less than 25 years and there's a family history. Genetic syndrome with autosomal dominant inheritance. It's an autosomal dominant inheritance. MODI, genetic mutations are involved. HNF1 alpha 70%, HNF1 beta, HNF4 alpha, glucokinase. Gene testing is important to identify the type of MODI as treatment differs according to the type. So in case of MODI, you have to go for gene testing. Other causes of diabetes: drugs, steroids and thiazides, pancreatic diseases, pancreatitis, surgery, pancreatic cancer, hemochromatosis and cystic fibrosis, endocrine diseases like Cushing's, acromegaly, thyrotoxicosis, pheochromocytoma, and pregnancy. Others like glycogen storage diseases and insulin receptor antibodies. Blood glucose may be temporarily high during an acute illness and after trauma or surgery, or during short courses of blood glucose raising drugs like secondary causes. If HbA1c is more than 48 millimoles per mole, diabetes mellitus is likely. Testing for diabetes. Consider referral for an urgent less than 2 weeks direct access CT scan or ultrasound scan if CT is not available to assess for pancreatic cancer if the patient is aged more than 60 years and there's weight loss and there's new onset diabetes mellitus. Which test to use? Acutely unwell? Yes. Check capillary blood glucose and admit as needed. If more than and admit as needed. Acutely unwell? No. If he is less than 18 years, possible type 1 diabetes, pregnancy, anemia, abnormal hemoglobin, example sickle cell or spherocytosis. If the answer to any of these questions is yes, then check fasting blood glucose in millimoles per liter. If it is more than 7, check second fasting blood glucose. And if that is also more than 7, you categorize him as diabetes. In the other case, if it is 6 to 7, check the glucose tolerance test. And if the glucose tolerance test is more than 11.1, then it is diabetes. If it is 7.8 to 11, it is pre-diabetes. If it is less than 7.8, normal, no evidence of diabetes. If the answer to any of these questions is no, or no to all, check glycosylated hemoglobin HbA1c. If less than 42, normal, no evidence of diabetes. 42 to 47, pre-diabetes. More than 48 is diabetes. For patient with symptoms, polyuria, polydipsia and weight loss, one FBG is sufficient. If no symptoms are present, confirm the FBG with a second sample. Consider confirming an abnormal HbA1c with a second sample. So if asymptomatic patient, you have to do all these things, even the FBG and HbA1c twice to confirm as diagnosis, as diabetes. Diagnosis of diabetes, that was the flow chart. Presentation. Acute. Ketoacidosis or hyperosmolar non-ketotic coma. Subacute. Weight loss, polydipsia, polyuria, lethargy, irritability, infections, candidiasis, skin infection, recurrent infection, slow to clear, genital itching, blurred vision, tingling of the hands and feet. With complications, skin changes, neuropathy, nephropathy, arterial or eye disease. Asymptomatic, incidental finding or through risk stratification. Risk stratification. Use a risk stratification tool, example diabetes risk score or Q diabetes, to assess all patients more than 40 years or more than 25 years of South Asian, Chinese, Afro-Caribbean or Black African origin from heart to reach populations, example homeless, or with other medical conditions that predispose to diabetes, example pancreatitis. If low or intermediate risk is there, give a lifestyle advice and reassess in less than 5 years. If high risk or South Asian, Chinese, ethnic origin, BMI more than 23 kg per meter square, check FBG or HbA1c. Management will be as in table 11.1. We already saw the management table. We will see the table. Pre-diabetes, non-diabetic hyperglycemia. If the FBG is between 6.1 to 6.9 millimoles per liter or HbA1c is between 42 to 47, it is called prediabetes. Risk factor for diabetes and CVD. Follow up with annual FBG or HbA1c. 4% per year develop diabetes. Offer lifestyle advice aiming to normalize blood sugar, as a 5% reduction in weight will result in 80% reduction in progression to diabetes over 3 years. Treat the CVD risk factors aggressively. Diabetes and pregnancy. Further information. So, NICE 2011 Preventing the Type 2 Diabetes Risk Identification and Intervention for Individuals at High Risk will be in this web link. And table 11.1 Diabetes risk stratification for high risk patients, FBG, HbA1c, and action. So, FBG fasting blood glucose is less than 5.5 millimoles per liter and HbA1c is less than 42. Provide lifestyle advice, reassess every 3 years. So, these are all high risk patients, but these are their values of FBG and HbA1c. If fasting blood glucose is 5.5 to 6.9 and HbA1c is 42 47, treat as prediabetes. If more than 7 and more than 48, consider type 2 diabetes. Organization and monitoring of care. Aims of diabetic care: elevation of symptoms, minimization of complications, decrease in early mortality, quality of life enhancement, education of the patient and family or carers. Features of well-organized care. User register and structural records are available as a part of in-house computer software. 6 monthly review with a recall system and follow-up of defaulters. Protocol for patient-centered care, including provision of personal care plans tailored to each individual and including self-management plans. Provision of protected time for the clinic. Availability of good quality written information for the patients. Open access for patients to receive advice. Multidisciplinary team covering all aspects of diabetes care. Example, GPs, diabetes nurses, specialists, assistants, educators, dietitians, podiatrists. Quality monitoring through audit and patient feedback. Continuing education for professional staff. Routine diabetic review. Each patient with diabetes requires a 6 monthly review or more frequently as necessary. This should include a thorough and annual review of all aspects of the disease care. Review should cover the problems, recent life events, new symptoms, difficulties with management since last visit, and review of indices of control like HbA1c, self-monitored results and discussion of their meaning, lifestyle, dietary behaviors, physical activity, smoking, diabetes education, including referral to structured education program for those newly diagnosed, and information on lifestyle and self-care support and when to step up treatment or seek further medical help. Skills, example, injection technique for patients on insulin, foot care, review of blood glucose, lipids and BP therapy and results. Other medical conditions and therapy affecting diabetes, immunizations, influenza and pneumococcal vaccination, and depression screening. Review of complications, annual review. More frequent if established complications, cardiovascular disease, nephropathy, neuropathy, eye disease, foot problems and erectile dysfunction. Review of services, annual review. More frequent if problems, analysis and planning. Agreement on the main points covered, targets for coming months, changes in therapy, interval to next review. Recording, completion of structured record plus or minus patient health record. 7 to 10% patients in long-term residential care have diabetes. Patients in residential care with diabetes tend to be neglected. Agree a diabetes care plan for each affected resident and ensure that at least annual diabetic review is done. Monitoring of blood glucose. All patients can achieve good levels of control as in table 11.2. Poorer control is acceptable to the elderly or others with limited expectancy of life as long as they are symptom free. Finger prick capillary glucose monitoring. Essential for all patients using insulin who are pregnant or who are pregnant. In addition, offer to people with type 2 diabetes if evidence of hypoglycemic episodes or oral medication that may increase the risk of hypoglycemia while driving or operating machinery. So, in all these cases, you can advise finger prick capillary glucose monitoring. Explain the range of suitable monitoring devices available and trained use of selected method. Frequency of self-monitoring varies according to need. Set targets for prepandal glucose levels. Assess skills and meters yearly if problems of self-monitoring. Evaluate reliability of results by comparison with HbA1c results and results obtained at review. Glycosylated hemoglobin HbA1c measure at least 2 times yearly. Represents the average blood glucose control over a period of past 6 to 8 weeks. Patients with type 2 diabetes who are taking sulfonylureas or glenides must check the blood glucose regularly while driving. So if you will need blood glucose meters and supply of testing strips. Indices of control. Capillary blood glucose millimoles per liter, fasting blood glucose when waking 5 to 7, pre-meals is 4 to 7, more than 90 minutes after eating is 5 to 7. Before driving is more than equal to 5. Urine, negative postprandial sugars less than 0.5%. HbA1c normal 20 to 42 per mole. Measure every 2 to 6 months depending on control. Type 2 diabetes. Drugs causing hypoglycemia less than 53 millimoles per mole. And diet control or drug not causing hypoglycemia less than 48 millimoles per mole. That is when the patient is on metformin, your adequate control, the level should be target level should be less than 48. And if you are adding a sulfonylurea, then the target level should be less than 53. So type 1 diabetes, target level should be less than 48 millimoles per mole. This is the HbA1c target. Serum cholesterol, aim to decrease the non-HDL cholesterol by 40% from the baseline. So whatever is the baseline, you are supposed to reduce it by 40%. BMI 25 to 30. BP less than 140 by 80 in uncomplicated type 2 diabetes. When it is type 1 diabetes, your BP targets are more stringent, 135 by 85. And if there is 130 by 80, if there is any renal, foot, eye or cardiovascular complications from type 2 or type 1 diabetes, so in case there is any complications, macro or microvascular, then you have to control the BP to less than 130 by 80. So in uncomplicated type 2 diabetes, 140 by 80, uncomplicated type 1 diabetes, 135 by 85, and if there is any complication, less than 130 by 80. Adjust the target to of the individual. If very elderly or limited life expectancy, relax the HbA1c aiming just to keep the patient asymptomatic. Management of diabetes education. Education is an essential aspect of diabetic care. Diabetes is a chronic condition and however it is well managed in the clinic. The patients must manage their own disease and the rest of the time. Anyone with diabetes should receive education through structured or quality control education program. Example, diabetes education and self-management for ongoing and newly diagnosed Desmond. Education enables patients with their carers and their carers to become equal partners in management of the disease. So general knowledge or information about diabetes and its progressive nature, complications, aims of management, structure of diabetic services and ways to access them, equipment required and usage instructions, syringes, needles, blood testing equipment, etc., free prescriptions if requiring drugs or insulin to control diabetes, problems of pregnancy, females of childbearing age only, alert bracelets, tags, Medicalert or Meditag provide engraved jewelry, watches and tags. Diet. Patients do not need a separate diet from the rest of the family for or expensive diabetic food products. A diabetic diet is a healthy diet. Aim for 50% more than 50% of calorie intake from fiber-rich carbohydrate with minimum fat, especially saturated, refined carbohydrates and alcohol. Adjust total calorie intake according to the desired BMI. If overweight, aim for initial 5 to 10% weight loss. Consider referral for bariatric surgery if referral criteria are met. Recommend more than 5 portions of fresh fruit or vegetables per day. Spread food intake evenly across the day. Diet sheets are available from Diabetes UK and should be provided. Ready-made meals or processed meals and alcohol are often sources of hidden sugar. Immunizations. Offer an annual immunization influenza and a single dose pneumococcal vaccine to all patients with diabetes. Spread food intake evenly across the day. Diet sheets are available from Diabetes UK should be provided. Ready-made meals, processed foods and alcohol are often source of hidden sugar. Immunizations offer an annual influenza and single-dose pneumococcal vaccine to all patients with diabetes, even though they are diet controlled. Psychological problems. Discuss concerns about diabetes mellitus. Arrange a counseling or refer for self-help resources as needed. Teenagers with diabetes can be particularly difficult group to manage. Often control is poor due to a combination of rapid bodily changes and rebellion against the diagnosis of diabetes. Support information and advice given in specialist clinics. Exercise. Encourage regular exercise. Review the attack at work and in getting to and from the workplace. Hobbies and physical activity in home. Advise physical activity can increase insulin sensitivity, decrease the BP, and improve the blood lipid control. If appropriate, suggest regular physical activity tailored to individual ability, brisk walking for 30 minutes per day, exercise prescription. Smoking. Advice on assistance with smoking cessation and foot care. Driving. Group 2 license bus and lorry on insulin or sulfonylurea or a glenide medication, inform the DVLA. 1 year license is issued if full awareness of hypoglycemia is present, no episodes of severe hypoglycemia in the past 12 months, monitor capillary blood glucose 2 times a day regularly even when not driving and less than 2 hours before starting a journey and every 2 hours while driving. Must use a blood glucose monitor with a 3 months memory function. Other diabetic medication must notify the DVLA but can drive and diet control, no need to inform the DVLA. This is in case of Group 2 license or bus and lorry license. In case of Group 1 or car and motorcycle license, insulin control, inform the DVLA, may drive if adequate awareness of hypoglycemia is present or less than 1 episode of severe hypoglycemia while awake in the past 12 months and last episode more than 3 months ago. Capillary blood glucose monitoring less than 2 hours before the journey and every 2 hours while driving. Sulfonylurea or glenide medication. No need to inform DVLA. Must be under regular medical review. May drive if adequate awareness of hypoglycemia is present and less than 1 episode of severe hypoglycemia while awake in the past 12 months and last episode is more than 3 months ago. Capillary blood glucose monitoring for insulin if needed clinically. Usually, if new medication less than 3 months, if any episodes of hypoglycemia or decreased awareness of hypoglycemia is present. No need to inform the DVLA. Diet controlled or other anti-diabetic medications, no need to inform the DVLA. So these are the rules and regulations for Group 1 license holders. Drivers should also inform the insurance company. The other conditions associated with diabetes like visual impairment, CHD may preclude driving. Employment. Advice on those on insulin that certain jobs are no longer possible. Example, working on scaffolding or dangerous machinery, joining the police or armed services. Jobs without these hazards should pose no problems, although the patients might wish to tell his or her employer. Special advice may need to be needed for shift work. Travel. Be aware of insurers catering for diabetic travelers. Give advice on management of change in time zones. No need to change with oral medication if taking insulin less than 4-hour time difference and less than 4-hour time difference. Transport and storage of insulin needs refrigeration in hot climates. Keep monitoring or injecting equipment in hand luggage. Differences in insulin types and concentration between the countries. Travel related illness, especially gastroenteritis. Need for immunization and travel insurance. Treatment of type 2 diabetes. Always combine the drug treatment of hyperglycemia with lifestyle measures and modification of other risk factors for vascular complications. Healthy eating and exercise. Diet is the cornerstone of diabetes treatment. Diet sheets are available in Diabetes UK. Increased physical activity is also beneficial. Decrease in weight, decrease in lipids and increase in insulin sensitivity. These are the benefits of increased physical activity. Usage of anti-diabetic drugs, we'll see in figure 11.2. Anti-diabetic drugs, what are the options we have? Biguanides, metformin 500 milligrams TDS, decrease the gluconeogenesis and increase the peripheral utilization of glucose. Only effective if some endogenous insulin is present. Hypoglycemia is not a problem. Start with minimum dose and increase every month until control is achieved. Maximum dose is reached. If not tolerated, try a modified release preparation. Avoid or stop if eGFR is less than 30 milliliters per minute. You need to avoid or stop metformin. Sulfonylureas, glycoside 80 milligrams or 160 milligrams BD, augment insulin secretion. Only effective if some endogenous insulin production is present. All are equally effective. Advise and take before meals. Warn about hypoglycemia if meals are omitted and need for blood monitoring if he is a driver. Start a minimum dose and increase the dose of blood until the blood sugar is controlled or maximum dose is reached. Wait more than 1 month in between adjustments. Main side effect is weight gain. Dipeptidyl 4 dipeptidyl peptidase 4 inhibitors or DPP4 inhibitors or gliptins. Example, sitagliptin 100 milligrams OD, linagliptin 55 milligrams OD. Useful if renal failure as excreted via the gallbladder. Linagliptin is useful in renal failure as it's excreted by the gallbladder. Inhibits the breakdown of glucagon like peptide 1, GLP-1. This decreases the blood glucose and levels by increasing insulin secretion from the pancreas, decreases the glucagon secretions and slow gastric emptying. May cause hypoglycemia but is very uncommon. Gliptins may cause hypoglycemia but is very uncommon. GLP-1 mimetics, exenatide, liraglutide and lixisenatide. These increase the insulin secretion, decrease the glucagon secretion, and slow the gastric emptying. Consider with metformin plus sulfonylurea if a triple therapy has failed, and weight loss might benefit other comorbidities. BMI more than 35 kg per meter square or BMI less than 35 kg per meter square, but insulin treatment would have significant occupational implications, then you can use exenatide or liraglutide. May cause hypoglycemia. Warn about the need for blood glucose monitoring if he is a driver. Avoid if eGFR is less than 30 per minute per meter square or 50 for some MR preparations. Continue if after 6 months only if HbA1c has reduced more than 11 millimoles per mole or weight has reduced more than 3% of initial body weight, rarely associated with ketoacidosis or pancreatitis. Pioglitazone 15 milligrams OD decreases the peripheral insulin resistance, does not cause hypoglycemia, may increase the weight. Check LFTs before and regularly during the treatment. Increased risk of bladder cancer, bone fractures and fluid retention, and heart failure. Avoid if risk factors for these conditions exist. Sodium glucose cotransporter inhibitors or SGLT1 2 inhibitors or glyphogens. Example, canagliflozin 100 to 300 milligrams OD, dapagliflozin 10 milligrams OD, empagliflozin 10 to 25 milligrams OD. Act on the proximal tubules of the kidney to block reabsorption of glucose back into the bloodstream, resulting in decrease in blood glucose, cause weight loss and may cause UTIs or genital thrush. Avoid if age is more than 75 years or eGFR is less than 60 milliliters per minute per meter square. Rarely may cause diabetes ketoacidosis even with normal blood glucose, so warn the patients. Rapid-acting insulin secretagogues or repaglinide or natiglinide stimulate insulin release, rapid onset and short duration of activity. Take half an hour before the meals. Avoid if age more than 75. Hypoglycemia is a common side effect and warn about the need for blood glucose monitoring if he is a driver. So this is a table. Diet and lifestyle modification. If HbA1c is less than 48, continue monitoring every 6 months. So if once HbA1c is more than 48, start metformin. Target HbA1c should be to reduce it to less than 48. This is metformin monotherapy. If it is not tolerated, metformin is contraindicated like in renal failure cases. Then DPP4 or pioglitazone target HbA1c to less than 48 or a sulfonylurea where target HbA1c should be aimed at less than 53. So after these two, the first line, and if the HbA1c is still more than 58 despite optimal monotherapy, give metformin plus DPP4 or pioglitazone or sulfonylurea or SGLT2. Target HbA1c to less than 53. Dual therapy. DPP-4 plus pioglitazone in case metformin is not tolerated, then either DPP-4 plus pioglitazone, DPP-4 plus sulfonylurea or sulfonylurea plus pioglitazone. Target HbA1c to less than 53. HbA1c more than 58 despite optimal drug therapy. Then triple therapy. Metformin, sulfonylurea, DPP-4 or sulfonylurea or SGLT2. Sulfonylurea or pioglitazone, pioglitazone plus SGLT2. Target HbA1c to less than 53. So any of the combinations you can use. If HbA1c is still more than 58, triple therapy, advise insulin. Continue metformin and review the need for other antidiabetic drugs. Start insulin. First line NPH, isophane insulin, OD or BD plus short-acting insulin. So it is a basal bolus regimen. If the help is needed for injecting BD, NPH insulin needed and or disabling hypoglycemia, consider insulin detimer or glargine. So NPH is the preferred one, and if there is some help needed or disabling hypoglycemia with NPH insulin, then only you need to consider insulin detimer or glargine. Consider a short-acting insulin analog if patient prefers. Hypoglycemia as a problem or marked increase in blood glucose before the meals. So even after triple therapy, if HbA1c is more than 58, then you can also consider metformin plus sulfonylurea plus a GLP-1 mimetic if the patient is, if it will help the patient. Insulin, first line treatment for diabetes and used when diet plans plus oral therapy have failed for type 2 diabetes. Local guidelines govern who does what. All drivers must notify DVLA and their insurance company. Insulin passports or patient information booklets offered to all patients receiving insulin provide a record of patient's current insulin preparations and contain a section for emergency information. The patient information booklets provide advice on the safe use of insulin. Types of insulin. Rapid acting analogs. Insulin Lispro, fastest acting. Peak is 0 to 3 hours after injection. Last 2 to 5 hours and given just prior to the meals. It's a rapid acting insulin, and effect lasts only 2 to 5 hours and is given just prior to the meals. Soluble, clear, human, porcine or bovine insulin, act rapid. Short acting, peak 2 to 6 hours after injection, lasts 8 hours, given 15 to 30 minutes before meals. Isophane, NPH or cloudy, human, porcine or bovine insulin, Humulin, I, Insulitard, intermediate or long acting, peak action is 4 to 12 hours after injection, lasts up to 30 hours. Taken OD or BD provides background insulin. Long acting insulin analogs like insulin detimer or glargine last 24 hours, provide background insulin associated with decreased risk of hypoglycemia. Pre-mixed or combination of short and long acting insulin 30-70 ratio. Injection regimens. Type 1 diabetes offer a multiple daily injection basal bolus regimen as first line. Use insulin detimer BD as a basal insulin therapy and OD insulin detimer or insulin glargine are alternatives and as a rapid acting insulin analog before meals. Other options include BD human mixed insulin regimen if multiple daily injections are not possible or BD analog mixed insulin if human mixed regimens cause unacceptable hypoglycemic episodes. So consider adding metformin to insulin therapy for adults with type 1 diabetes and a BMI more than 25 kg per meter square or 23 kg per meter square of South Asian origin. Type 2 diabetes. Continue to offer metformin if already taking. Review continued need for other antidiabetic drugs. Suitable insulin regimens are for type 2 diabetes, once or twice daily intermediate or long-acting NPH insulin. Consider acting a short-acting human insulin separately or a pre-mixed preparation if HbA1c is more than 75 millimoles per mole or HbA1c targets are not met. Once daily long-acting analog, insulin detimer or glargine is an alternative if help is needed to inject or unwilling to inject BD. If unacceptable hypoglycemic episodes are present, consider an insulin analog, insulin detimer or glargine instead of human insulin. Biphasic preparations contain short-acting insulin analogs are also useful if blood glucose levels increase markedly after meals. So, overall, grossly, in case of type 2 diabetes, whenever insulin is needed, the first option would be NPH insulin. Whereas in case of type 1 diabetes, the first option will be analog insulins or detemir or glargine. Administration: deep subcutaneous injection to the upper arm, the thigh, the buttock, or abdomen. Fat hypertrophy and scarring are minimized by rotation of injection sites. Pen devices or syringe needles are equally effective. Primed needle using an air shot, an empty needle decreases the insulin dose by 2 units. Rock pens containing pre-mixed insulins to mix contents. Increased absorption can occur if a limb is exercised following an injection. Insulin pumps. Continuous infusion of rapid-acting insulin may be considered in a specialist settings if type 1 diabetes and more than 12 years with repeated unpredictable hypoglycemia or inadequate glycemic control, HbA1c more than 69 millimoles per mole despite optimized multiple injection regimen, or less than 12 years of age and multiple injection regimens are impractical or inappropriate. So, continuous infusion when you have to suggest if type 1 diabetes and is more than 12 years old with unpredictable hypoglycemia and inadequate control, or patient who is type 1 diabetes less than 12 years old in which multiple injection regimens are impractical. Then you give insulin pump. Monitoring. Check the blood glucose preprandially more than one per day at different times. More often, multiple injection regimens after dose changes or during intercurrent illness. Ask patient to keep timed or dated diary of readings. Many meters do this automatically. Record episodes of hypoglycemia. Target blood glucose to 4 to 7 millimoles per liter pre-meals and hypoglycemic episode kept to a minimum 4 to 8 millimoles per liter pre-meals if less than 18 years old. Starting insulin for a patient with type 2 diabetes. Use a structured program. Appropriate training is needed for all practice staff involved. Before starting, teach home blood glucose monitoring, reinforce the diet, continue metformin plus other antidiabetic drugs, teach insulin injection techniques. Start 10 units of intermediate or long-acting insulin. Teach patients or carers about self-disposal of sharps and hypoglycemia. Give instructions to increase dose every 7 to 10 days until target levels are reached. Example, average fasting glucose more than 10 millimoles per liter. Increase by 6 to 8 units per day, and 8 to 10 millimoles per liter increase by 4 to 6 units per day, and 6 to 8 millimoles per liter increase by 2 to 4 units per day. This is an example of sliding scale, how you should increase the insulin dosage. You start at 10 units and then you increase as per the fasting blood glucose levels. Provide a contact telephone number for advice. Follow up after 2 to 3 days and then as needed. Check HbA1c every 3 months until stable. So you give this chart, sliding scale, to the patient and start them on 10 units of intermediate or long acting insulin and then give them this chart and then ask them to check the fasting blood glucose every day. If it is more than 10 in the fasting, then increase by 6 to 8 units per day, and if it is 8 to 10, increase by 4 to 6 units. If 6 to 8, increase by 2 to 4 units per day, and then that day they will increase, next day they will again check and again they will increase the units according to which category they are falling. Exercise. Decrease the insulin dose at the time of exercise or take 1 to 2 glucose tablets before exercise, then check the blood glucose afterwards. Adjust the alterations of glucose dose with experience of effects of exercise. Intercurrent illness. Continue insulin in usual dose and keep a regular check of blood glucose. Consider blood urine ketone monitoring for adults with type 1 diabetes. Maintain glucose intake even if not eating with glucosol or milk. If more glucose is more than 13 millimoles per liter, increase insulin by 2 units per day until control is achieved, or use top-up injections of short-acting insulin QDS PRN. Admit to hospital if condition warrants admission, unable to take glucose, persistent vomiting or dehydration. Ketotic, check the urine if blood sugar is more than 13 millimoles per liter. Poor control. Exclude intercurrent illness. Consider diet or gastroparesis. Consider psychological factors. Check psychosocial factors. Check insulin is being used correctly. Check injection sites are not scarred or hypertrophic. Consider changing insulin dose. Ask the patient to record the glucose profile, blood sugar pre-meals and before bed. If using more than one insulin, adjust one at time one at a time, increase or decrease as needed. So alter by less than 10% each time. Allow 48 hours between dose adjustments. Alter insulin dose. Dose of insulin acting at the time of blood sugar is at the time the blood sugar is most out of control. So this is when patient is using more than one type of insulin. So at that time, you have to alter the insulin dosage one at a time. Not both all the types you cannot alter at the same time. Start with one insulin which is most dose. Alter the dose of insulin acting at the time of blood sugar is out of control. Hypoglycemia and diabetic renal disease. Hypoglycemia. Suspect if known diabetes or oral insulin therapy. Short history. Warning signs or symptoms are usually present: sweating, hunger, and tremor. If untreated, may progress to odd, violent behavior, fits, and ultimately coma. On examination, the patient may be sweaty and have tachycardia and raised BP. Younger children may present atypically with behavioral changes or headache. Emergency management. Check a capillary blood glucose on blood testing strip. Suspect hypoglycemia if less than 2.5 millimoles per liter. If confirmed, if conscious, give simple carbohydrate, 3 glucose tablets, 100 ml of milk or a sugar containing soft drink, Lucozade, 5 sweets, jelly bar babies or glucogel. If unable to take oral carbohydrate, give IM glucagon 1 milligram. Children less than 25 kgs, 0.5 milligrams. Take less than 5 minutes to act but may have poor effect if the patient is starved or drunk. Alternately, IV glucose, adult 50 to 250 milliliter of 10% solution in 50 liter of liquids. Child 2 to 5 ml of per kg of 10% solution. Once the patient has regained consciousness, supplement with simple carbohydrates as per conscious patient and some symptoms improve. Give complex carbohydrate, example biscuits. Repeat glucose testing in less than 15 minutes, then monitor hourly blood sugars over the next 4 hours and 4 hourly for 24 hours. Maintain a high glucose intake for several hours if the patient has severe episode of hypoglycemia due to an oral medication. Review reasons for hypoglycemia. Advice for patients. Check the blood sugar before driving and every 2 hours during a long journey. Carry glucose everywhere and sandwiches on long journeys. If warning signs of hypoglycemia occur, stop hazardous activities and take action. Wait until fully recovered, usually 45 minutes before resuming activities. In case of severe hypoglycemia, supply a responsible member of the family with glucogel and glucagon injection. Teach him or her to use it. Response is short-lived. Give oral glucosade or glucose tablets or milk as soon as the patient is conscious. Recurrent hypoglycemia. If recurrent hypoglycemia occurs in a regular pattern, check the pattern of meals and activity and alter the insulin to match the needs. If erratic, consider erratic lifestyle, alcohol, problems with absorption, errors in administration or gastroparesis. If no obvious cause, consider change in underlying insulin sensitivity like due to age or CKD. Hypoglycemia unawareness. To restore the warning signs, adjust insulin or food intake to stop glucose levels dropping to less than 4 millimoles per liter. Consider undetected nighttime hypoglycemia if HbA1c is lower than expected from blood sugar diary. Driving is not permitted if hypoglycemia awareness has been lost or more than one episode of severe hypoglycemia while awake in the past 12 months. No episodes permitted for Group 2 license. So we will stop here and tomorrow we will continue from page number 325. Thank you friends. Have a good day.